Hi everyone, welcome to 1 p.m. Just a reminder that you're listening to the summary version of this episode.
You're an intern on the ward. You have just learned about 2 types of respiratory failure in a morning seminar. The nurse gives you an ABG which shows a PaO2 of 47 on room air. CO2 is normal. What kind of respiratory failure is this?
Yeah, so I would look at the whole ABG and compare the PaO2 and the PaCO2. But because the CO2 is normal, this seems likely for a type 1 respiratory failure.
And what would you expect the clinical features to be?
So the clinical features I'd expect would be like increased work of breathing, like tracheal tug, some recessions, abdominal breathing, some peripheral cyanosis perhaps, maybe altered mental status or lethargy.
Pretty comprehensive. Explain the key investigations you would like to carry out, Jason.
Investigation-wise, some bedside investigations would be putting an oximeter on them to look at their oxygen saturation. Blood tests, I would consider doing a full blood count, an ABG, a CRP, LFT, UECs to get some baselines. Imaging, I would consider doing a chest x-ray and even a CTPA if a pulmonary embolism is a differential diagnosis.
There's a micro category as well.
Yes. Yeah, I'll do a sputum MCS.
Depends on what.
Depends if a pneumonia is suspected or another infectious cause. And then just a full body MRI to finish. Okay. I think that's...
Yeah, I was waiting for you to get to the full body MRI. Explain the relevant management.
So in terms of management, you'd like to start off with A to E approach and then just have a low threshold to call for help. But in terms of airway assessment and then breathing, important to start maybe with like the non-breather mask, maybe 15 litres, a high oxygen saturation, and then just assess clinically how they're doing. And with the FiO2, you'd probably want to assess whether if that is more than the threshold that you said before, I think 40, you'd want to refer to ICU or step up there.
It's not a hard rule, but that's kind of alarm bells territory for most people. Sounds good. The other example was you're an intern on the ward. You've just learned about the 2 types of respiratory failure in a morning seminar. The nurse gives you an ABG which shows a PaCO2 of 75. What kind of respiratory failure is this, JT?
Because the PaCO2 is more than 50, so I'm suspecting type 2 respiratory failure.
Yep. Explain the clinical features you expect to see.
Because type 2 is what I'm suspecting, it's mainly an issue where they can't breathe or they don't breathe. Because of the increased CO2 in their system, they're a bit like altered mental state or they seem a bit drowsy. On general observations, they might look a bit obese if they're having other central neuromuscular disorder issues that are causing their breathing to be impaired.
Yeah, so this can be a pretty vague presentation. They might just be a bit restless, tired, like you said, altered mental status. Towards the severe end, like all respiratory failures, if you leave them untreated, can lead to death. These people can get, in type 2 respiratory failure, myoclonus, seizures, coma, respiratory arrest. So you got to treat it. Can't just ignore it. Explain the key investigations that you would like to carry out, Jason.
I'd consider, like imaging-wise, a chest x-ray to look for any signs of COPD if it hasn't been diagnosed yet. ABG to look at their levels, their PCO2. I don't know if you want to look at their drug levels, if you suspect if it's an overdose from opioids. I don't even know if you can do that.
Yeah, you can't really. It's just like clinically, just do they respond to naloxone or not? Have they had any? Like you would know it on the med chart. So investigations is probably just basic bloods that you do as part of a med call, including an ABG, and then doing a chest x-ray. Because, just because they have type 2 respiratory failure doesn't mean there isn't something else going on. They could have infective exacerbation of COPD, and they've also got like a bit of a pneumonia as well that you might pick up on a chest x-ray. So always good to do a chest x-ray. And then specific targeted investigations to what you think the underlying cause is.
Treat the underlying cause, JT. Don't just give them oxygen.
And then the last question is explain the relevant management. Sanchita.
So in terms of management, you probably want to target the breathing first with, depending on what the cause is, if it's COPD, maybe they could benefit from some high flow oxygen, which can then be stepped up to BiPAP. However, if none of those measures kind of correlating to any clinical benefit, you can step up to more non-invasive ventilation methods and then more invasive with intubation and you would definitely want to consider referral to ICU before.
ICU has been involved, yeah.
Yeah.
Yeah, sounds good. Nice work, guys. Yeah, sorry, it's a bit of a complex topic, but there will be notes coming out of this. So the 3 first principles. Type 1 respiratory failure is an oxygenation issue, so you need to give them more oxygen. Type 2 respiratory failure is a ventilation issue. You have to make them breathe more. Either they can't breathe or they won't breathe or some other thing with the actual, usually mechanics of them breathing. Mm-hmm. And then third is you can't really assess their oxygenation without an ABG. Don't feel afraid to do an ABG in these patients where they've got respiratory failure because pulse oximetry has its limitations.